which speaks to the wisdom of the FIPS office in asking us to address all of this particular constellation of issues. We're deeply grateful to the FIPSA program for their support in recognizing and addressing the many complex issues survivors and their children face in dealing with the mental health and substance use effects of domestic violence and healing from their traumatic effects. We're also deeply grateful to the FIPSA program and the Office of the Assistant Secretary for Planning and Evaluation for partnering with us in this initiative to raise awareness about substance use coercion, and more importantly, to develop strategies to address its far-reaching effects on all the systems that we all work in and all the systems that impact survivors' lives. Finally, we're deeply appreciative of Commissioner Darling's active support and engagement with this important and groundbreaking work. This is a disclaimer saying that we're funded by the grant we're funded from by the Administration on Children, Youth, and Families, and that the disclaimer that what we're saying today doesn't necessarily reflect the official positions or policies of the U.S. Department of Health and Human Services. I'm going to pause for a minute to make room for the Commissioner Elizabeth Darling, from Commissioner of Administration, Children, Youth, and Families, to make remarks.
Thank you. Can you hear me?
Are you on, Commissioner Darling?
I am. Can you hear me?
Yes. Can I read your bio before you speak? I wasn't sure if you were on, so I didn't start with it.
Yes, you may.
Thank you. So Elizabeth Darling is the Commissioner at the Administration on Children, Youth, and Families, ACYF, at the Administration for Children and Families at the U.S. Department of Health and Human Services. ACYF has two bureaus under Commissioner Darling's leadership, the Children's Bureau and the Family Youth Services Bureau. In addition to her Senate-confirmed position in the Trump administration, she also serves as the Acting Associate Commissioner at the Family and Youth Services Bureau within ACYF. Commissioner Darling was most recently the President and CEO of One Star Foundation, which was created to support the state of Texas by strengthening the nonprofit sector. And before that, she was the Chief Operating Officer of the Corporation for National and Community Service within the federal government. Prior to those responsibilities, she served as Deputy Secretary at the Maryland Department of Human Services. In that capacity, Commissioner Darling had oversight of child care, child support, child welfare, domestic violence, and family assistance programs, in addition to overseeing the state's temporary assistance for needy families, food stamp, and Medicaid programs. Commissioner Darling's current position as ACYF Commissioner represents her second appointment at HHS. During the Bush administration, she was the founding director of HHS's Center for Faith-Based and Community Initiatives, an office that continues to provide valuable support, including for ACF programs. Before coming to HHS for the first time, Commissioner Darling served as the Vice Chairman of the Texas Department of Human Services, overseeing welfare to work programs under the landmark 1996 Welfare Reform Act. Elizabeth Darling has a Bachelor of Science in Education from Baylor University and is an adoptive mother with 3 children and 2 grandchildren. So it now gives me great pleasure to turn this over to you, Commissioner Darling.
Thank you so much, and we should have given you the short bio. My apologies for that. It's my pleasure to welcome everyone today and to start this webinar that's being held during Domestic Violence Awareness Month. Within the Administration on Children, Youth, and Families, we support the Family Violence Prevention and Services Program, or FIPSA, which for more than 35 years has helped survivors of domestic violence and their children by providing shelter and supportive services. If you're not familiar with the FIPSA program, we reach 1.3 million survivors each year by supporting more than 1,500 local domestic violence agencies and the 24-hour hotline. 1 year ago, we were pleased to partner across HHS with the Office of the Assistant Secretary of Planning and Evaluation to host a day-and-a-half-long technical experts meeting on substance use coercion. I had the privilege of attending this meeting, and I learned so much. This event was also coordinated with the National Center on Domestic Violence, Trauma, and Mental Health, which is one of our national special issue resource centers. We appreciate the countless hours that they have invested to identify substance use coercion as an issue, create responses for the field, and work with us on the materials that we will be sharing today. During last year's meeting, we hosted 50 attendees representing experts from throughout HHS and other agencies, along with national advocates, researchers, and practitioners. I personally learned a new vocabulary and became better informed about this issue, recognizing that substance use coercion creates major barriers to safety and recovery for survivors of domestic violence. The Federal Technical Experts meeting greatly improved our understanding about the prevalence and impact of substance use coercion and generated thoughtful recommendations for policy, research, and practice. Underlying this rich discussion was the opportunity to listen to women who have experienced and survived substance use coercion by an abusive partner. We heard clearly that we need to ensure that people with lived experience are driving the process, and that services and outreach efforts need to meet people where they are, both emotionally and geographically. Talking with you today, the world feels vastly different than it did a year ago. Certain states, whether under stay-at-home orders, saw domestic violence rates rise as much as 30% since the beginning of the COVID-19 pandemic. Local programs continue to report an increase in calls for services as survivors are being able to once again seek help. Meanwhile, over 40 states have reported an increase in overdose deaths during COVID-19. These conditions highlight how the issue of substance use coercion is more important than ever for HHS and our partners to better understand and address. I look forward to today's webinar, and I will now turn it over to Dr. Warshaw to continue. Thank you so much. Dr. Warshaw?
Thank you, Commissioner Darling. Again, really grateful to you and our partners at ASPE and for supporting this really important and critical work. And we're excited today to be able to share some of the highlights of the meeting, some of the important insights and innovative work from some of the meeting participants and panelists, and also recommendations for policy, research, and practice that were generated both by some of the preparatory research we did. We did a lit review and a key informant interviews, and both of those reports are going to be available today and launched on our website, as well as the meeting report that you can see the cover of here. As you've heard, substance use coercion is a really critical issue that cuts across service sectors and systems. And so we're going to try to touch on all of the dimensions in this short time period, but hope you'll read all of the reports that have a lot more depth about what we've been learning. And as we continue to do this work and engage with all of you, we continue to learn more both about forms of substance use coercion, the impact on survivors, and about innovative strategies for addressing it. The way we're going to structure the webinar today, I'll provide a brief overview of research on substance use coercion for those of you who are less familiar, and I'll touch on the implications for pressing public health concerns such as the opioid epidemic, and and along with specific implications related to COVID-19 that Commissioner Darling, you just mentioned. And then we'll have a very exciting panel that will touch on lived experience, innovative programming in DV programs and substance use disorder treatment settings and in tribal communities. Next, Kenya Fairley from the Family Violence Prevention and Services Program will provide an overview of some work by the FIPSA program, and Kenya and Laura Erickson from ASPE will share highlights from a policy brief developed by FIPSA and ASPE. Finally, I'll come back and talk about some of the recommendations and some of the ideas that were generated by meeting participants and key informants for how we can all move together going forward. So this is just a brief summary, kind of in a nutshell, of some of what, where we started in doing this work. We know that intimate partner violence has significant mental health and substance use and trauma-related effects, and we'll go through each of these in a little more detail in a minute. And that people who access substance use disorder treatment services experience high rates of intimate partner violence and other trauma. We also know that people who abuse their partners actively use substance use-related issues against their partners as a tactic of control, which is what we refer to as substance use coercion, which impacts survivors' ability to access and engage in treatment as well as DV services, and impacts them in many other ways that we'll talk about shortly. And to bring that all together, what we've learned and what we know is that integrated approaches to trauma, substance use, and intimate partner violence are really critical to the recovery and safety of survivors and their children, and that often services have been quite siloed and systems are siloed, and part of what we'll keep talking about is how can we work together to make sure that nobody falls through the cracks and that people are met where they are. So I'm going to go through some of the research in a little bit more detail, but still at a kind of overview level. So research has consistently documented the impact of intimate partner violence on mental health and substance use. I want to point out that survivors experience higher rates of PTSD, depression, suicidality, chronic pain, insomnia, and substance use, and specifically opioid use. Part of what's interesting when we think about the kind of health and mental health effects of intimate partner violence, there are also things that can contribute to substance use and opioid use, including chronic pain, which may be related to physical injuries or to the painful medical conditions related to the trauma of abuse, whether it's intimate partner violence or abuse across the lifespan. Insomnia that may also be related to PTSD or depression, or just to stress and living with abuse, but also because abusive partners keep their survivors up all night as another form of control and debilitation. So just thinking about them all together, even the research has been siloed, and yet when we're looking at the lives of survivors, they're very much intertwined. You can see that the rates of PTSD, major depression, and self-harm are 3 times as high when someone's experienced intimate partner violence versus when they haven't. Suicide attempts are 4 times as high, and we know there are increasing rates of suicide right now during the COVID pandemic, but rates of substance use and substance use disorder are 6 times as high for people who are experiencing intimate partner violence. One of the things we know is that research up to this point has looked at them as co-occurring, but hasn't really looked at the reasons why that might be the case, and we'll show you some data on that in a minute. We also know that intimate partner violence is prevalent among people who are accessing substance use disorder treatment, and you can see on the left some of the data. Rates of lifetime domestic violence in substance use disorder treatment settings range from 47 to 90%, depending on the study. There's wide variation in questions and methodology in all those studies, and part of why we see that range, but you can see it's very, very high. And the reports of domestic violence in the past year range from 31 to 67%, and we kind of use past year as a proxy for being at ongoing risk. So that's very high rates of people who are in substance use disorder treatment or experiencing ongoing domestic violence. We also know, and this is from a study that we have a report of some of the highlights that we distributed at the meeting, and we'll have a full report out in the next month or so, conducted by our research team. This is a national survey of 527 DV programs, and 56% of programs reported an increase in past 2-year opioid use, and 37% of programs reported an increase over the past 2 years of methamphetamine use. So just looking at what programs are seeing and what survivors are dealing with. Less well recognized, and hopefully this won't be less well recognized for much longer, are the ways that people who have used their partners engage in coercive tactics targeted towards a partner's mental health or substance use as part of a broader pattern of abuse and control, and that's what we'll be focusing on today. Common forms of substance use coercion include, and we'll look at some of the data in a minute, deliberately introducing a partner to substances and then forcing or coercing a partner to use, interfering with a partner's ability to engage in treatment and sabotaging their recovery efforts, and then leveraging the stigma that's associated with substance use, particularly for women who are parenting, to discredit a partner with potential sources of protection and support and to jeopardize their ability to maintain custody of their children. And so that's a really critical piece. It's not just the direct impact of an abusive partner's coercive behavior on a survivor and their children, but also their ability to leverage systems to mobilize them against their partners. And the other piece that we see a lot is exploiting a partner's substance use for personal or financial gain. This comes up like coercing a partner into engaging in illegal activities or selling drugs or into sex trafficking. Next slide. So one of the things that we know, and many of you know this as well, that domestic violence survivors and advocates have been talking about these issues, these forms of abuse for many years, and that when we did the Lit Review, led by Heather Phillips, our research director, that there were lots of qualitative descriptions of these tactics in a number of research studies, but when we did a search for substance use coercion, what mostly came up was people being coerced into substance use disorder treatment. So the first large quantitative study we conducted in partnership with the National Domestic Violence Hotline, actually in 2012, and over 3,000 callers, 26% said they'd ever use substances to reduce the pain of partner abuse, but 27% said they'd been pressured or forced to use alcohol or other drugs or made to use more than they wanted. These were not people who were necessarily using substances or who were in substance use disorder treatment. These were random callers to the hotline. And of the 15% who said they'd sought some kind of help or treatment for substance use, over 60% said that their partner tried to prevent or discourage them from getting that help. So just think about that for those of you who are in substance use disorder treatment field or recovery support field, what that would mean for people that you're working with in your practices or programs. Over 37% said their partner threatened to report their substance use to someone in authority to keep them from getting something they wanted or needed. Sometimes that was protection orders, sometimes that was services, and often that was related to custody. And almost 25% said they were afraid to call the police because their partner either said they wouldn't be taken seriously because they were using or that they would get arrested. And we also know who is usually left holding the bag. We know that incarceration rates for women are largely related to substance use and substance use-related crimes. So some of the qualitative data that participants shared included being initiated into using, and we know that survivors are often introduced to substances by an intimate partner and who play a major role into substance use initiation and into the escalation of substance use-related problems to the point of people developing a substance use disorder. Coercive tactics range from being pressured to use with a partner and not being able to refuse to being manipulated or threatened or coerced into using and to literally being forced into using or being drugged. We also heard a recent report of coercion, the partner being asked, pressured to use to quote unquote calm down so they wouldn't be so angry with their partner after having been beaten. When we talk about treatment interference and recovery sabotage, there are a couple of ways this happens. One is being prevented from attending meetings or treatment by withholding transportation or child care, threatening a partner if they do attend, or literally harassing them out of treatment. It used to be calls, and now it may be incessant texting. They're also trying to control someone's medication, keeping substances in the home after someone returns from treatment, using in front of a partner, trying to entice them to use, and escalating violence as someone tries to stop or cut down. stories we've heard from survivors about threats to report them to authorities or to discredit them. We've heard not only related to custody, but to judges, to police and probation officers, to employers, making false allegations, literally forcing someone to use or drugging them, then videotaping them in a debilitated state, and then presenting that to Child Protective Services. We also heard survivors talking about substance use-related sexual coercion, being pressured to use in the context of sex or being forced to use, and then blaming the abuse on the partner's substance use and using that as a way to undermine them, and benefiting from the lack of services related to stigma, where someone can't access DV services because they're using, or they can't access a sober home. Emily Rothman's research in Vermont, because people are afraid that they'll be stalked and it won't be safe. So lots of barriers that get presented that people who abuse their partners deliberately play on. So what we see is that experiencing a mental health or substance use disorder places individuals at even greater risk for being controlled by an abusive partner. And it's really that stigma that allows abusers to so successfully engage in these tactics. And that's part of why the work to really raise awareness among all of the systems that survivors engage in is so critical, and for all of you who are working with those systems, whether in them or working in partnership with them. And this is sort of, just want to highlight that, as many of you know, that people who abuse their partners also actively try to undermine survivors' relationships with their children, which not only creates risks for children, but also really undermines their partners as well. We also know that while exposure to intimate partner violence can impact children's physical, psychological, and emotional well-being, research consistently shows that attachment to the non-abusive primary caregiver is what's most protective of children's resilience and development. And we also know that prevention and early intervention efforts are effective in reducing child abuse and intimate partner violence. This has particular salience, particularly when we talk specifically about the impact on opioids, that in 23 or 24 states, using substances during pregnancy is considered child abuse, even if someone's on medication-assisted treatment. And yet we know that neonatal abstinence syndrome is often the time of an infant going through that is reduced when they are able to be in bond with their mother. So there's lots of implications of this for people working in the child welfare space. So this is just a kind of way of looking at this all together, this constellation of intimate partner violence causing a whole range of mental health and substance use related effects, abusive partners actively inducing mental health and substance use related effects, and undermining a partner's sanity, sobriety, and parenting, then controlling access to treatment and sabotaging recovery, and then using it against partners, and that's the stigma that they're able to leverage that allows them to do so. So again, we all have critical roles to play, and I hope as you're listening today that you're thinking about how this impacts the work that you do, the people you work with, and the systems you interface with. I'm going to touch on two things before we go to the panel. One is thinking about the implications of substance use coercion for the opioid epidemic. So first of all, just some context around opioids. We know that intimate partner increases a person's risk for opioid use, and I'll show you some specific ways that happens on the next slide. We also know there are high rates of intimate partner violence among people who are accessing opioid use disorder treatment. In one study, 90% of women who were attending a methadone clinic had experienced intimate partner violence. That's a lot of people. We also know that women who experience intimate partner violence are at increase for relapse and for opioid-related overdose. Dr. Louisa Gilbert, who was a panelist at the meeting, reported in her remarks that in a study of 352 women in community correction settings, if they had reported intimate partner violence, they were 61% more likely to have experienced a drug overdose. And that research hasn't been published yet, but hopefully will be shortly. We also know that IPV and opioids have increased during COVID-19. As Commissioner Darling mentioned, in over 40 states, there's been an increase of opioid-related overdoses since the onset of COVID-19. And we also know that IPV and substance use coercion create unique risks that directly threaten safety and well-being, particularly in the context of opioid use. So these are some of the unique ways that substance use coercion plays out in the context of opioid. We've talked already about introducing a partner to opioids and controlling their supply. And controlling a person's supply is a way of really maintaining abuse and control, power and control over a partner. Once your supply is being controlled and you have to face the threat of withdrawal, and that there are lots of ways that contributes to people being trapped in abusive relationships. So there's a deliberate initiation into use to the point of developing an opioid use disorder, then controlling a partner because of their opioid use disorder. Forcing a partner to use unsafely. We've heard lots of stories of partners being forced to use dirty needles or cotton that induces a lot of medical complications, including things like endocarditis. And if you're working in a healthcare space, we've heard stories of people coming into the ER with multiple episodes of endocarditis and people getting frustrated and saying, why should we keep treating them, and not thinking about the context, not that people should be doing that anyway, but also adding another dimension of this context. Coercing a partner to engage in illegal activities through the threat of withdrawal, and particularly around human sex trafficking. And again, once a partner is involved in the criminal legal system, then there's tremendous leverage that a partner has. We've heard stories of abusive partners coercing a survivor to use and then calling their probation or parole officer. We also know that really impacts survivors' ability to access benefits that they might otherwise be eligible for. So there's lots of ways that abusive partners can leverage a person's use of opioids and coerced engagement into illegal activities to maintain their control over them. There's also we've also heard stories of partner abusers deliberately injuring their partners and then sending them to the ER to obtain opioids. When we think about treatment sabotage in the context of opioid use disorder, it's having to attend regular meetings like for medication-assisted treatment, particularly in the context of methadone, which is hopefully somewhat mitigated with COVID-19 where people can do more take-home medications. It's easier to be stopped when you're keeping regular appointments. Often there are particular regulations for being able to attend treatment at certain times, not being late, not missing sessions. That makes it very hard for people to maintain their treatment and recovery without considering how an abusive partner is sabotaging their ability to participate in treatment. And then jeopardizing economic stability. So lots of things to think about for those of you who are providing opioid treatment or working with survivors who use opioids. And then thinking about this, again, the constellation of mental health effects, chronic pain, leading to greater risk for developing opioid use disorder and opioid overdoses, compromised access to treatment, and increased risk for sexual coercion, coercion-related criminal justice system and child protective service system involvement. I'm just going to touch on the impact of COVID-19 and then turn it over to our wonderful panel. As you've heard, that the impact of substance use coercion has been amplified in the context of COVID-19, and we know that intimate partner violence is more frequent and severe, and there are more severe injuries, more pain. There's an increase in coercive control, that survivors are trapped at home with abusive partners. They have less access to resources for safety and support, and there's more opportunity for an abusive partner to sabotage their mental health treatment and recovery. We also know there's an increase in mental health conditions, substance use, and suicidal ideation. During COVID-19, partly due to the stress of COVID and abuse-related trauma, isolation, and financial difficulties. People may not be able to access their usual coping strategies, and there are also some telehealth-specific barriers around having an abusive partner in the home who may be listening in or preventing someone from accessing treatment via telehealth, as well as tech safety concerns around being able to track what someone's doing in the digital trail or other ways to hack into systems that are less secure. So now I'll turn it over to the panel. I want to talk about what else we've learned about responding to substance use coercion in the last 12 months. Gabriella, are you on? I'm not able to hear you.
Thank you so much for letting me know. I forgot that I was muted on both the web app and my phone, so I only had muted one of those. Thank you so much. Sorry about that, everyone. So I'm Gabriela Zapata Alma, and I'm honored to moderate this panel. First, we're going to hear from Jeanette Garcia. Jeanette has worked at Haven's Women's Center for 23 years, providing domestic violence and sexual assault services in welfare to work programs, child welfare, women's jails, Stanislaus Family Justice Center, Stanislaus State University, and in substance use disorder treatment centers. And she has 28 years clean and sober. So our first question for you, Jeanette, is as a service provider working with survivors of substance use coercion, as well as a member of the recovery community, how have you seen substance use coercion being used to endanger survivors and their children?
Hi, it's great to be here in many of the ways that I've already heard, and then I'll just share kind of my thoughts where I am. So whether coercion to use substances is done in a threatening or intimidating manner to instill fear, or in a sweet, seductive, begging, or pleading manner to manipulate the survivor's emotions, abusers have a keen understanding that by coercing the survivor to use substances, it increases their dependence on them, as well as dependence on the substance. Therefore, it's easier for the abuser to control their partner. Abusers will sabotage survivors who have open CPS cases by coercing them to use or by putting drugs in their food or drink so they test dirty. By using systems and substance use coercion, they're often effective at making the survivor appear noncompliant with a CPS case plan or even exited from treatment. Abusers will often coerce their partner to use alcohol or marijuana, saying, "You can have wine," or "You never had a problem with weed," their goal being to sabotage the survivor's recovery, shame them, and lead them back to drugs of choice. Perpetrators will physically and emotionally abuse the survivor, prohibit them from seeking medical care for injuries, and then coerce them to use substances to ease the physical and emotional pain. Perpetrators know that they can use the survivor's substance use history or even successful completion of treatment against them in court to gain custody of the children. This puts the children at great risk, causes the survivor to feel hopeless, and then they're unable to protect their children from the abuser. I can't tell you how many survivors have ended up incarcerated or charged with crimes that belong to their abuser. The most common examples are when the survivor is threatened or coerced by the abuser to say that a weapon or drugs are theirs. Several survivors have shared experience such as, "We were driving and we were pulled over by law enforcement. My abuser put the drugs in my purse and told me that if I love him, I would say it was mine, that I wouldn't get in trouble because I don't have a criminal record." When survivors are incarcerated, the children often stay with the abuser or placed in foster care. And again, many, these are just a few.
Thank you so much. And then as a survivor of substance use coercion, would you share with us what helped you to establish safety and recovery? What got in the way or was harmful? And then what's still needed to better support survivors and their children?
Sure. Before I share about what helped me establish safety and recovery, I want to tell you a little bit about me. My dad was an alcoholic and died at age 44 of cirrhosis of the liver. He was homeless in the street when he died. I'm the oldest of 7 children. My stepdad battered my mom for 30 years. I suffered from the trauma of witnessing horrific violence as well as sexual abuse throughout my childhood. I began medicating the pain with alcohol at age 8 and was addicted to meth by age 15. Drugs and alcohol worked to keep me from committing suicide. The violence of my childhood continued into my adult life. It was the only thing I knew, and it felt normal. My last abuser was my drug connection, and his substance use coercion kept me in the relationship on and off for 7 years. At the lowest point of my addiction, I called the Narcotics Anonymous hotline and began attending 12-step meetings. At NA, I met my sponsor who had worked for a domestic violence agency. She informed me of resources such as Haven Women's Center for safety planning, advocacy, and case management. I also enrolled in substance abuse services for outpatient treatment. Support groups for trauma and addiction were where I found my first connection to others, women who had experienced many of the things that I had. Up until that time, I always felt alone. When I saw how others were healing physically, emotionally, mentally, and spiritually from trauma and shame, it gave me hope that maybe I could have a different life. With that sliver of hope, I was finally able to leave my abuser for the last time when I had 6 months clean and sober. My daughter was 2 years old. I was homeless for my first 3 years in recovery. I struggled with depression and anxiety. I was referred for a mental health evaluation and counseling. Learning about post-traumatic stress disorder and symptom management helped me a great deal. I applied for cash aid and food stamps. Since I was already enrolled in school when I applied for AFDC, I was granted a self-initiated program to continue my education. I utilized the Welfare Homeless Program to obtain my first apartment. Children's Crisis Center provided child care. Many things helped me: financial aid, scholarships, tutoring, state vocational rehab, parenting classes, the recovery community, my church, music, my faith. The people who demonstrated empathy and believed in me and had a deep understanding of addiction and trauma made all the difference in my life. I got a job at Haven. Employment and insurance are also critical to success. I learned how to have fun, clean, and sober, and I'm still learning about self-care. I've had many mentors throughout my journey, people who've come alongside with experience, strength, and hope, and I'm forever grateful. I would say what got in the way are many of what has already been shared: poverty, homelessness, the stigma of addiction, systems that don't hold the abuser accountable for crimes committed, and instead of assisting and protecting the victim is blamed, especially in child welfare where the victim is accused of child endangerment or failure to protect. Couples counseling is dangerous when there's a history of violence, but it is often done in churches by untrained clergy or in mental health systems by therapists who don't recognize the controlling tactics that an abuser is using. Court-ordered co-parenting sessions where the abuser and the victim are in the same class. Family court is at the top of the list of what was harmful to me. I didn't always get separate mediation when I requested it, and I had a restraining order. My danger was escalated by court orders for visitation, having to transport my daughter to the abuser, and denying supervised visitation. Court was a huge barrier because of continuances. My abuser wouldn't comply with court orders, and instead of holding him accountable, the judge would continue the case. I would have to miss class, treatment, or work, find child care and deal with the anxiety of seeing my abuser, escalating my danger over and over again. It took years to get any child support and to finally get a divorce. Abusers are able to harass and control the victim by manipulating and using every system: law enforcement, child protective services, TANF, welfare fraud, courts, the list goes on and on. I had difficulty navigating services that were compartmentalized and were not trauma responsive. There were constant contradictions. For example, in treatment, we spent weeks on assertiveness and setting boundaries. I was encouraged to set boundaries with my abuser. We even did role-played scenarios. I tried to explain how that escalated my danger, and the facilitator said, "You're allowing him to treat you that way." Coercive and controlling tactics used in treatment centers were harmful. For example, in order to move on into the next phase of treatment, it was a requirement that we read our autobiography out loud to a large group of our peers. Many were abusers that were court-ordered to treatment. Due to the sexual abuse I experienced as a child, I didn't feel comfortable sharing my autobiography at group level. I asked my counselor if I could read it privately, but I was told that in recovery we must be honest, open-minded, and willing, and also that secrets keep us sick. I have many examples of being forced to comply with requirements of various programs in order to receive services. Barriers such as child care, transportation, lack of insurance, other basic needs were also huge things that got in the way. And lastly, I'd say for recommendations, change TANF and welfare to work programs, extend the time that a person can be on aid when there's mental health, substance use, or domestic violence issues. When the time clock stops due to a welfare to work exemption, supportive services such as bus passes, child care, and treatment must continue. Change core hours to empower people who want to get an education. Working minimum wage jobs won't meet the basic needs for a family, especially a single parent. Currently, people on TANF that are in school opt out of welfare to work, discontinuing the adult portion of the cash aid in order to pursue their education. Improve services by cross-training staff and provide training on trauma-responsive care. Training can't be a one-time thing. It has to be ongoing and repeated. Section 8 housing is often the difference between achieving success or being homeless. Our county accepts Section 8 housing applications about every 5 years, and people are waiting up to 10 years to get their Section 8 certificate. Access to mental health services, access to substance use disorder treatment, mandatory training for DV, SUD, and mental health for judges and mediators, especially those in DV and drug courts. More training for law enforcement and having the right officers in the specialized units. We must have collaborative, holistic service provision by providers who are cross-trained to provide trauma-responsive care. This includes physicians and faith-based organizations. We need early interventions in schools to train teachers how to recognize behaviors associated with trauma, teaching ways to create a safe, trauma-responsive classroom, to stop suspending and expelling children who are having difficulties or acting out. And lastly, continued funding for domestic violence, mental health, and substance use treatment, as well as supportive services that empower families to thrive in nonviolent homes.
Thank you so much, Jeanette. And as we see, there's so much that needs to be done, but also so many opportunities for being able to really improve the kinds of supports that survivors have access to as they establish safety and recovery and economic stability. Thank you so much. So now introducing Gwendolyn Packard, Ihunk Tawan, Dakota, who is a training and technical assistance specialist for the National Indigenous Women's Resource Center, where she has worked for many years. And she has worked for many years in Indian country, both at the national and tribal level. She has served as editor for 6 national Indian publications. In 1990, she was instrumental in founding the National Organization on Fetal Alcohol Syndrome. She served as executive director for Morning Star House, an advocacy program that works with off-reservation Indian women and children who are victims of domestic and sexual violence. She has also served as executive director of the New Mexico Suicide Prevention Coalition and is founder and co-chair of Rain Cloud, the off-reservation behavioral health collaborative in Albuquerque, New Mexico. She is a survivor of domestic violence, a writer, a grassroots organizer, and community activist. She has made a commitment to social change and working to address social and economic justice issues that affect the health and well-being of Indian people. We're so glad to have you today, Gwen. So, how have you seen substance use coercion creating barriers to safety and recovery for survivors and their children in tribal communities?
Aniwashte. Hello, everyone. I'd like to thank the National Center on Domestic Violence, Trauma, and Mental Health for the opportunity to be part of this important conversation and to share information about Indigenous people and tribal nations. The dynamics of substance use coercion in the context of domestic violence in tribal communities is pretty much the same as you would see in non-native communities. Where there are significant differences is in the availability of resources and access to culturally appropriate services. In addition, the depths of trauma in American Indian and Alaska Native communities run steep. Unresolved grief and trauma continue to play a huge role in terms of violence, substance use, and mental health issues. Unfortunately, our communities continue to experience high rates of domestic violence, substance use, suicides, and mental health issues. These issues are not separate. They are intricately intertwined and connected. Tribal domestic violence programs and shelters are incredibly diverse and different. Very seldom are they autonomous within their tribal communities. It's important to note that there are fewer than 44 tribal shelters in the whole country. And treatment programs are probably even scarcer, not to mention access to culturally appropriate treatment services. Lack of resources and access to culturally appropriate services is significant when you consider Native American women and men continue to have the highest rates of victimization, with 84.3% of women and 81.6% of men experience violence in their lifetime. We also experience high rates of domestic and sexual violence, stalking, dating violence, trafficking, and missing and murdered. 18% of American Indian Alaska Native adults require substance use disorder treatment, almost twice the national average. And deaths from complications related to alcoholism, homicide, and suicide are 2 to 6 times as high among Native Americans as they are among other populations. In addition, housing shortfalls and lack of affordable housing continue to pose major challenges in tribal communities. Tribal domestic violence programs and shelters are co-located under the management of many different tribal programs, such as social services, health clinics, health centers, behavioral health, law enforcement, and the courts. And all these different programs often dictate the way the work is done and the lens through which the services are provided. This can create barriers for safety and recovery for survivors and their children, especially if there is not a coordination of services in effect and there is a lack of focus in understanding the critical impact of domestic violence. And of course, COVID-19. We've had a lot of challenges in tribal communities, and this pandemic has dramatically highlighted every single one of them, along with the introduction of new and additional challenges. As Indigenous peoples, we know that change is very much a part of our traditions, and this pandemic has brought a lot of changes to the way we live, work, and address safety in our communities.
Thank you so much, Gwen, for sharing all of this with us. So what innovative approaches and traditional practices have tribal programs used to respond to substance use coercion?
Sure. I just want to say first off, there are currently 574 diverse federally recognized tribes in the U.S. So I don't mean to generalize here, except that it's impossible to speak about all the different activities and practices that are taking place all across the country in these diverse tribal sovereign nations. Sense contact, preservation of language and culture, along with ceremony and traditional practices have played a key role not only in our survival, but in our mental, spiritual, emotional, and physical well-being. So much of the important life-changing work in tribal communities has come from the voices of survivors. Valuing the voices and contributions of those with lived experience has played a significant role, and that's come from the people. Recently, we've seen incredible change when tribes are able to examine and decolonize their existing frameworks, breaking down silos, being good relatives to each other, and understanding that everyone is important and everyone has a role to play or a song to sing, and becoming loving people again. Those are the things that have been most effective in responding to domestic violence in the context of substance use coercion. Being good relatives to each other, letting people know they have that support, let them know that there's someone is there for them. I think of, just the acts of human kindness have just been the greatest and most effective responses to this.
Thank you so much. And now introducing Amanda Sedgwick, DO, who is a psychiatrist in charge at McLean Hospital, Alcohol, Drug, and Addiction Inpatient Program, and in the Adult Outpatient Services. She is fellowship trained in women's mental health. Dr. Sedgwick specializes in substance use disorders and co-occurring conditions, including trauma. Her area of interest is in treating women with substance use disorders and co-occurring exposure to intimate partner violence. So Dr. Sedgwick, Since attending the Federal Technical Experts meeting last year, how has substance use coercion impacted the stability and recovery of survivors and their children in your treatment setting?
Thank you so much, Gabriella, for having me. Certainly, pre-COVID, we were seeing significant difficulties for survivors in navigating recovery and treatment for substance use disorders. Survivors were dealing with partners interfering in their treatment, sabotaging their recovery efforts, and isolating them from supportive recovery communities. For the most part, many were able to navigate treatment and carve out time to physically get to appointments in group. They shared that attending groups was a relief and sometimes the only time that they had to themselves to connect with safe support. One very positive shift is that substance use coercion seems to make it into the conversation much more easily than traditional screenings for domestic violence for women who are in substance use treatment. They're often much more willing to talk about the coercive measures taken by partners to interfere with their sobriety, their treatment, or contribute to relapse than they are to discuss domestic violence in more traditional ways. Now, with COVID restrictions in place, navigating telehealth and working from home has brought new challenges and exacerbated some old challenges. Some survivors currently living with abusive partners have had much more difficulty accessing treatment. I've seen abusive partners limiting internet access, not allowing privacy for appointments, expecting survivors to bear the full load of childcare and homeschooling, sometimes while also maintaining full-time jobs. I've seen them interfering with remote work, causing more fear for job security and financial stability. Some abusive partners have chosen this very vulnerable time for survivors that have relapsed during COVID to follow through with threats to involve children's services to take their children away. Some abusive partners have falsely reported survivors to law enforcement, and when this has resulted in charges against survivors, they have repeatedly threatened to testify against them if they leave. Many of these charges during this time have been deferred or postponed, so it's resulted in continued leverage over survivors. I've seen the fear of leaving abusers increase because the alternative is uncertainty and risk of COVID exposure. Many survivors have said that they've been scared to call shelters or scared to enter treatment facilities, most of which are some kind of shared living space. We have discussed at length in my outpatient groups telehealth safety pretty regularly and have developed recommendations and agreements within our group around the telehealth safety.
Yeah, so tell us more about that. So as a treatment provider, what have you been able to put in place to address substance use coercion and support survivors and their children?
So for the past few years, I've been running an outpatient group, which is an intervention for women with substance use disorders who are survivors of intimate partner violence. It consists of an 8-week curriculum with themes of prioritizing both safety and recovery. And it's really a place for women to connect around their similar struggles and support one another week to week. The curriculum provides a framework for them to learn about things like substance use coercion and other common triggers, and also teaches them skills to use when they're feeling unsafe or trying to navigate treatment or intense home situations. The way that they share their own journeys with each other is really, I think, the process that helps them develop insight into their own situation, and it motivates them to make the changes necessary to keep moving towards safety. We've also been doing some education for staff and patients to help engage women in discussions around substance use coercion very early on in their treatment. So at the inpatient level of care or in detox facilities, it's sometimes not possible for women in these situations to participate in the prolonged treatment programs like residential treatment or 30-day programs for their substance use. So we try to introduce this and notice it early on and make sure to connect them to DV resources wherever possible. Many women early on in treatment don't realize that DV is a part of their story, especially when there isn't a strong component of physical abuse. And sometimes recognizing substance use coercion in their relationship can be the first step in considering this at all. It's always a goal as well to continue to work closely with the local DV advocacy programs because they do such a great job of supporting survivors through these complicated situations outside of their treatment. Often, as treatment providers, our community outreach is pretty limited, so partnering with local advocates is a very, very important part. Thanks so much, Gabrielle.
Thank you, Dr. Sedgwick. And now, last but certainly not least, to hear from Angie Pye. Angie Pye brings over 20 years of experience working in the domestic violence field with particular experience in community coordination in rural areas. She has served as the CEO of Beacon Center since 2016, and prior to that served as the executive director of the Lee Conley House. In her role as executive director, Angie started a program to increase access to services for survivors of DV, also dealing with substance misuse. Prior to that, she worked for the Florida Coalition Against Domestic Violence for several years and Another Way Incorporated as a program director from 1997 to 2009. As a program director, she worked directly with survivors and their children, supervised 2 shelters and outreach offices in 7 rural counties. She also worked with local child protective services and the community-based care agencies to bring survivor-focused services to families. So, Angie, thanks so much for being here with us today. And my first question for you is, as the executive director of a DV advocacy organization, how has substance use coercion impacted the safety and recovery of survivors and their children in your residential programming?
Hi. Thank you. Good afternoon. First off, it has affected them in a lot of the ways that you've already heard from the other panelists. And I'm so sorry. One of the biggest threats to their safety is that if they also are struggling with this issue, they're afraid to report. And abusers, of course, use that to encourage silence and also call and report them for their drug use. I really just had a call yesterday from somebody who she's been away from him a year, and he called her housing and told him that she was a drug user and was prostituting to try to have her evicted. So that piece of it continues to go on even in their efforts to separate from the abuser and impacts their safety out in the community as well. When they first come into shelter, a lot of the survivors that we see are really concerned about being out in the community. If he has also been their supplier of the drugs, he may have told friends or other people that he provides drugs to that she's left, and so therefore there's a lot of eyes on her out in the community. So when they first come into shelter, especially if they're already talking about wanting to make efforts at recovery, we really start talking about those kind of issues early and start safety planning through them. So if they are out in the community or if they are still using and are not at the place that they're ready to stop, that we can talk about the safety if they do that, where there will be, who will be around, will they be able to safely return back to the facility, and what we need to do to help and support them in their safety during that really dangerous time.
Wow. Thank you for sharing that with us and for including that just most recent example. So what kinds of services and strategies have you put in place to counteract substance use coercion and support the safety and recovery of survivors and their children?
It's really what we learned from the project that we started in Putnam was, first and foremost, being able to really openly talk about this and to make sure that we created materials and the handbooks or the educational information that we may share in the shelter or give them when they enter, when they get their shelter resident handbook, for instance, that we are already talking about this as a common issue that we see, that when people experience trauma, it's not unusual that they look for a way to numb that trauma. And so that if they are struggling with that issue, we want to just create as much openness about talking about it as we possibly can. So we really looked at our empowerment-based model and kind of compared it to the common substance treatment that they were getting from our local community mental health and substance abuse agencies, for instance, and found a way to make sure that we were using that same empowerment-based philosophy with the substance misuse. So we separated the two issues. We make sure that they don't see the abuse that they have have withstood with their partner as their fault because they have been using drugs or alcohol. We make sure that we really talk about it in a way that separates those two issues, so they don't carry that. We worry about that sometimes in drug treatment or AA, that in their steps to take responsibility for things and make amends, that they don't feel that the abuse with their partner is something that they need to make amends for. For example, we train staff in motivational interviewing. We made sure that we got advocates training around this issue and talk about things that they may see and how people may respond when you're talking about this, train them on stages of change and how to identify that. Relapse prevention training, talking about people, places, and things. And we actually had recently a woman that overdosed in the shelter, and she went to the hospital. They did not keep her in treatment when she came back to the shelter. So we hit this challenge of this overdose just happening and her not being able to get to a detox. And we just sat down with her and really had a conversation about what we would need to make sure that she was safe at the shelter and that she was getting what she needed. And we came up with a relapse prevention plan and getting her to meetings and finding her a sponsor. And I was so excited last week that we got to write a check to pay first month's rent for her to move into her own independent housing. She's almost 90 days clean and she's just doing amazing. And had we, as a shelter, exited her for that overdose and said we couldn't let her come back, I don't know that she would have survived. Putting her back out on the street and taking away a roof over her head because of that overdose, to me, that's just not a justified response. So we really have taken the time to train the staff on how to manage that and to have an open conversation about a plan and to be honest with them about what we need to see and what our expectations are, and then support them in making those decisions. We also have a primary staff that is trained around these issues. She's trained as a peer recovery partner or mentor, and she does trauma incident reduction and unblocking, and we work with a therapist to utilize those tools, and that's been a really helpful thing too, and we're actually building off of that now to create peer partners with some of the survivors that have gone through our program that have gotten into recovery, that are in a good place and want to give back, training them to be able to come in as peer partners. So we have a peer partner that specifically understands the substance misuse as well as the domestic violence component and the challenges of the systems that they'll come in contact with. So we really work on really normalizing the issue and making sure that it's a part of everything that we do, that people can reach out about it and know that they're not going to receive judgment. And we also really look at the safety. One piece of it with kids, we do a lot of work with the Department of Children and Families, and this is a difficult issue for them, as well as domestic violence. And domestic violence and substance abuse together is really challenging for them to identify safety and protective capacity. So we've really incorporated work into our advocacy with the department to talk through parenting capacity, protective factors of the parent, not just assuming because a parent has a substance misuse issue that they're not a good parent, to be able to look at the full picture and the efforts for safety for their children and the things that they've done to protect their children, and help develop relapse prevention plans also in a way that it includes child safety, so we can help build that survivor's resilience and the tools that she has when she gets out into the community on her own and faces struggles again, that she'll be prepared, that she'll know what to do. This is still just a really challenging issue there, because children get removed sometimes because of the domestic violence, and then it's not uncommon to see the children be given back to the violent parent over the mother who may have a substance misuse issue, even if she's clean and has been clean for a period of time. If she has a history, that tends to get used against her as well. So these two issues are going really hand in hand for us, because we see so many survivors that are struggling with both, and it's like being behind two locked doors. You're already dealing with the judgment of the choice and partner, and now you're dealing with the judgment of your drug use and your ability to move into recovery or to not do that anymore. So those are the things that we're working on and continue to train and expand on within the DV organization that I'm at now, to try to counteract some of those challenges for the survivors we see.
Thank you so much. Thanks so much, everyone, every one of our panelists, for sharing your experiences with us today. And now I will hand it over to Kenya.
Kenya, you might be on mute. I'm not able to hear you.
I did my entire introduction. So thank you for letting me know that you all could not hear me. Hello, everyone. Thank you for being on the webinar this afternoon. I'm Kenya Fairley, Supervisory Program Specialist with the Family Violence Prevention and Services Program, housed in the Family and Youth Services Bureau in the Administration for Children and Families.
Hi, everyone, and I'm excited to be joining Kenya. I'm Laura Erickson. I'm a social science analyst in the Office of the Assistant Secretary for Planning and Evaluation.
So October is National Domestic Violence Awareness Month. This is a time for advocates, survivors, and their loved ones, and the community to come together to mourn, celebrate, and connect. Along with many of those who stand in solidarity with us around this issue, we recommit ourselves each year during Domestic Violence Awareness Month to doing at least one thing to prevent and end domestic violence. In the FIPSA program, our one thing is partnering across federal programs and leveraging federal resources to better meet the needs of survivors and their children.
And just to give a little bit of background about our my office, ASPE, the Office of the Assistant Secretary for Planning and Evaluation, we sit under the Office of the Secretary, so we really provide cross-cutting policy and research analysis to the Secretary on across a number of health and human services areas.
And as I mentioned, the FIPSA program is housed in the Family and Youth Services Bureau, where our mission is to support the organizations and communities that work every day to put an end to youth homelessness, adolescent pregnancy, and domestic violence. FIPSA has made history by being the first time federal resources are dedicated specifically to expand and support domestic violence shelters, services, and programs, and we continue to serve in that purpose to this day. We fund more than 1,500 local public, private, nonprofit, and faith-based organizations that provide victims of domestic and dating violence and their children with shelter, safety planning, crisis counseling, information and referral, legal advocacy, and other types of supportive services in the community. SIPSA provides funding for a national network of training and technical assistance resource centers, culturally specific institutes, state domestic violence coalitions, discretionary grant programs, the National Domestic Violence Hotline, and Strong Hearts Native Helpline. The National Center on Domestic Violence, Trauma, and Mental Health is a part of this great network, and they really work with the programs that are providing services across a number of different systems to ensure that domestic violence survivors and their children receive the support, assistance, and help that they need to become independent and remain economically self-sufficient. So this initiative between ASPE and the FIPSA program, this initiative was really born out of the recognition of the high rates of domestic violence being disclosed and discussed in substance use treatment programs, as well as with consideration being given to the impact of the ongoing opioid epidemic crisis taking place across the country. In both FIPSA and ASPE, we realized the need to establish a general knowledge of substance use coercion in order to better prevent its occurrence and so that victims of domestic violence can receive critical, life-saving support and assistance. As Commissioner Darling stated earlier, we've been working to learn a new language and to share that information and this research with others across the federal government. So we know that substance use coercion has wide-ranging implications for survivors in terms of their access to treatment and recovery, their ability and capacity to remain sober, their access to mental health and other types of behavioral health services, impacts to child welfare, and their economic stability. So through this initiative and partnering with ASPE, we really wanted to ensure that we had a great understanding of what was taking place across the field. So doing a scan of the field and a literature review. We also worked with the National Center to conduct key informant interviews and then to do an analysis of the things that came out of those interviews. And we also worked together to host a technical expert meeting last year. And then finally, we developed a policy memo for federal agencies. And I'm going to pass it over to Laura to tell you more about that.
Yeah, thank you, Kenya. And based on that partnership that Kenya was talking about and the research that we've fortunately been able to do jointly with ASPE and FIPSA and the National Center, ASPE and FIPSA came together to create a kind of a short, easy to read, hopefully, policy memo that really discusses at a high level what substance use coercion is, and it discusses, some of our methods for arriving at these findings, as well as some key policy and practice recommendations that we heard from the field. And so I'll just give a quick overview of some of the findings, especially with all the conversations that we've had today. I'm sure most of these, if not all, are not at all surprising. But we did hear anecdotally from many of the folks that we spoke to that substance use coercion is very common, but the actual data collection is limited. We also heard that abusive partners often might try and leverage a survivor's substance use to control the survivor's access to things like employment, housing, or finances, and other key forms of economic support, which can greatly impact a survivor's economic stability. And then you heard earlier about the many various tactics that abusive partners use, and so we discussed that a little bit in the memo as well. And we also heard from key informants a number of policy and practice recommendations that we included in the memo. So those are things like, for example, people that we spoke to identified a wide range of activities that federal agencies can take, things like incentivizing collaboration through funding announcements that call out substance use coercion, things like evaluating innovative approaches, including some of the things that you heard about from the panel. Folks also noted that there are things providers in both the domestic violence and the substance use fields can do, like cross-training each other's staff, accepting children into substance use treatment, and including children in safety planning and other trauma-informed services. We also cover some of the recommendations that we heard about ways that the domestic violence and substance use fields can collaborate with other stakeholders, such as partnering with child welfare agencies or housing programs or the criminal justice system through either multidisciplinary teams, working together to educate policymakers, and coming together to address substance use coercion. And finally, we heard key informants, we highlight some key informant recommendations about the importance of implementing a wide variety of innovative models so that survivors can really access a variety of programs and choose the one that's right for them. So that might be things like programs that are led by peers with similar lived experiences, culturally responsive programs like Gwen discussed earlier, or programs that allow survivors to bring their children with them. Kenya, is there anything I missed on this before you discuss main takeaways?
No, I think you covered it all. Thank you. And so here are a couple of critical takeaways that we wanted to highlight for you all today. So we think it's very important to address the system-level issues that make it harder for survivors who are dealing with substance use coercion. And so those are some of the barriers that were discussed from our great panelists in sharing what their specific experiences were and some of the challenges that they had. We're also thinking about how can we better center the voices of people with lived experience of substance use and intimate partner violence, such as we did today, but also extending that out to make sure they're included and have an active role in the development of policy, research, and programming. So we want to make sure and leave that with you today as part of the takeaways. And we also want to share information with you about where you can access the policy memo for yourself.
Yes, so you are able to find this policy memo on our ASPE website. The link is here, and I can put that in the chat. You can also go to our website at aspe.hhs.gov and just search the term substance use coercion, and it should be the first result. And with that, I think we are now turning it back to Dr. Warshaw.
Thanks, Laura and Kenya. Well, so my role in the next 18 slides was to go into more depth on all the recommendations, but we made an executive decision or a collective decision during the panel to extend the panel. So what I'm going to do is a speed dating walkthrough of what's on the slides, which you'll get, but actually everything that's in the slides is explained in more depth in the reports that you'll receive and more succinctly in the policy memo. So just so you can see what they are, and then we'll do our closing remarks. So this is a combination of the meeting report and the key informant interviews. And again, these are the things that Kenya, you and Laura just talked about, system barriers, improving services, integrated approaches, cross-sector collaboration at the federal, state, and local level, thinking about the implications for opioid policy, building a research agenda, and, of course, centering the voices of survivors. So one of the things this is from the same survey I mentioned earlier, that the majority of DV programs reported an increased demand for substance use disorder treatment, but only 20% felt very prepared. 46% felt somewhat prepared, and fewer felt prepared when in settings where a woman was using substances and she was parenting as well. And I think, Angie, the work that you do around this intersection is so innovative, and there's so much more that you could share about this that we'll figure out ways for you to be able to do in very practical ways. We also did a survey of state substance use disorder treatment systems, and most of them, of the 26 who had responded, said they weren't doing collaborating, but really wanted to and thought that was really important. So expanding services, we just know there aren't enough resources, and cross-training, which we talked about, and really having a whole array of options for survivors. And again, encouraging services that meet the needs of survivors with children, which means accepting children into programming, providing child care, and offering two-generation approaches, which is really critical for, as you heard, for women being able to engage in services. For DV programs, it's really being inclusive and taking a harm reduction approach, and I think, Angie, you covered this really well, and I think we also heard, Jeanette, what are some of the barriers in substance use disorder treatment settings, including having a perpetrator in the same treatment setting, or whether it's your abusive partner or other people who are perpetrators of abuse and violence, and really reducing unnecessary restrictions so that people can engage in services and not have to follow rules that they can't follow or requirements in order to participate. Again, substance use disorder treatment, there's, some treatment modalities that address trauma and substance use, none that specifically address substance use coercion, although our toolkit does. If we don't have evidence yet, but we're working on it, and Dr. Sedgwick is also doing the same with a small research project, so hopefully we'll have more for that soon. Thinking about telehealth safety, that as this becomes embedded in federal policy, that there are protections put in place around telehealth and intimate partner violence. There's research on integrated services. Incentivizing collaboration at the state level as well is really important, and that's part of what our state partners said they would welcome and look for. Again, all of the systems where survivors experience barriers, we need to be reaching out to, thinking about things even like expungement, and educating workers and developing new strategies and revisiting policies going forward. And the last thing is a research agenda. Really, there's research on the prevalence and impact in like large national studies, but also qualitative studies to look at the impact in specific settings and contexts to make this more, people more aware of this, including in federal surveys, questions that already exist. Thinking about how to engage people in services who aren't engaged, that's a huge barrier, and really looking at building an evidence base for a range of approaches, including culture-specific and indigenous approaches. And finally, looking at the impact of policies on survivors experiencing substance use coercion. So again, we just want to end with centering the voices of survivors in the development of policy research and programming to address this really critical issue. There's no time for questions, but if you email us, we'll respond to all of your questions. And here are some of the many resources that we'll be sharing with you after the webinar.
Thank you so much, Dr. Warshaw. This is Tamar Westphal just jumping on to remind everyone that you will receive a follow-up email within a week that will have a link to the recording of today's webinar as well as all of the slides you've seen today. You will also receive links to all of the reports that we have mentioned, which will be published on the center's website, and you will get a certificate of attendance for joining us today. As soon as I close out the webinar, you will be taken to a very brief evaluation. We hope that you will take a moment to share your thoughts with us, let us know what was useful and anything that could have been better. Again, thank you so much for joining us, and we hope that you have a wonderful afternoon.